Welcome, everybody. Uh, my name is Larry Hoffheimer, and I'm the chairman and founder of the Macular Degeneration Association. Thank you for joining us today. This is a series of educational seminars for people that are experiencing macular degeneration, and we cover those subjects that you'll find on our website on a regular basis. Please go to macularhope.org, macularhope.org, to see a schedule of all our virtual programs. I also want to thank Regeneron, Novartis, and Notovision for their support in helping us to produce these programs. The Macular Degeneration Association is a nonprofit, tax-exempt organization, and its purpose is to provide a voice and information to the millions of people suffering from macular degeneration. Currently, there are estimated over 11 million people in this country that are suffering from macular degeneration, which is the leading cause of blindness for people over 50. So it is very prevalent, and there's a lot of activity going on both on the research side as well as the human side. So I want to introduce our speaker today and our subject, which is macular degeneration and depression. A lot of you have a lot of reasons. I'm sure that you're depressed, but how your vision can impact on that. We will hear from our next speaker, who we're very proud and pleased to have. He is Dr. Angelo Domingo. He's a Yale Fellowship-trained neuropsychologist specializing in treating emotional, behavior, and cognitive symptoms of chronic illness and dementia. He is also a caregiver support specialist. When you have your questions and answers, please go to the bottom of your screen where you'll see the Q&A box. Don't raise your hand, but type your questions in that box, and Dr. Domingo will answer your questions. Also, there's a survey at the close of the program. It only takes about 2 minutes to complete, and it helps us better serve you in the future for virtual patient programs. So without any further ado, it's my pleasure to present to you our speaker today, Dr. Angelo Domingo.
All right. So today's talk is called Overcoming Depression Associated with Age-Related Macular Degeneration. Reclaiming Your Life from Depression, a guide for people with AMD. There we go. So by the end of this talk, this presentation will have taught you what AMD is, and I'm only going to speak briefly about what AMD is, because I think we all know what AMD is, what depression is, how to identify the signs of depression, the causes of depression in both the general population and among people with AMD, why and how depression is linked to AMD, the ways depression changes how people with AMD think, act, and feel, how people with AMD can reverse these changes to thoughts, behaviors, and emotions, and the methods of managing depression associated with AMD. What you're going to find through the course of this talk is that depression in people with AMD is really not so different from depression in people with other general medical conditions or even, physically healthy individuals. So very briefly, what is AMD? So macular degeneration causes loss in the center of the field of vision. In dry macular degeneration, the center of the retina, also known as the macula, deteriorates. With wet macular degeneration, leaky blood vessels grow under the retina and interfere with macula function. The macula is the part of the retina at the back of the eye. It's only about 5 millimeters across, but is responsible for our central vision. Most of our color vision and the fine detail of what we see is due to the macula. So most of our color receptors are congregated in the macula. Oh, further away from the macula you get, the retina actually increases in sensitivity, but usually only responds to black and white. The macula has a very high concentration of photoreceptor cells, and those are the cells that detect light. So what is the prevalence of AMD? Approximately 0.4% of the general population has late or advanced AMD, with the prevalence of advanced AMD rising to about 8% among those 75 years of age and older. While the prevalence of all types of AMD has somewhat declined over the past decade due to enhanced medical prevention and treatment options, the number of people with all types of AMD is expected to increase due to the rapid and consistent growth of the aging population. Recent projections estimate that worldwide, the number of individuals with AMD will reach 196 million in 2020 and 288 million in 2040. So since we're already at 2021, I imagine we're somewhere in the low 200s mark at this point. So what is depression? Depression is a psychiatric illness that manifests itself as a change in the way normal people think, act, and feel. And I emphasize that, normal people, because it's normal at some point in one's life to experience some form of depression. And we don't necessarily mean major depression, which is what we see on a lot of these commercials for medications, people who are non-functional because of their depression. But there are other milder forms of depression. Depression is very common. And sometimes a small measure of depression is a very normal reaction to negative circumstances in one's life, like being diagnosed with a chronic condition like AMD. Depression is different, though, from grief or sadness because it usually causes prolonged, profound distress and gets in the way of living a normal life. Sometimes it only gets in the way in a minor fashion. Other times it can be a major impediment to living a normal life. Sometimes people get so depressed they can't function at work, or they isolate themselves and they don't socialize anymore. They may be putting their relationships and friendships in jeopardy. So also, unlike normal grieving or sadness, depression can persist for a long time, sometimes decades if it isn't treated. That's why early detection and treatment is so important. And in that sense, depression and AMD are very similar. Early detection and treatment are critical in AMD, and they're also extremely important in depression. So what are the signs of major depression? Depressed mood most of the day for at least 2 weeks. Loss of interest in activities for at least 2 weeks. Significant weight loss or weight gain. Insomnia or hypersomnia almost every day. So that is either having trouble getting to sleep, staying asleep, or sleeping too much, being fidgety or restless, or moving much slower than usual. So you can see here that some of these symptoms are exact opposites of each other. You either have insomnia or hypersomnia. You're either fidgety and restless, or you're moving slowly. That's because there are different forms of depression. Some people have what are called an agitated depression, in which case it's a depression mixed with anxiety and restlessness. Or they may have more of an apathetic depression, or a depression in which they have no energy, in which case they'll be moving much slower and sleeping a lot. Other signs of major depression include fatigue and loss of energy, feeling worthless or having inappropriate guilt, trouble thinking and concentrating. And in fact, trouble thinking and concentrating is a very common symptom of depression in the elderly. Often, I get people showing up at my office who think that they're developing a dementia, when in reality, they're just depressed, because I deal mainly with an older population. The great thing about having trouble thinking and concentrating because you're depressed is depression's treatable. And as the depression lifts, people's thinking and concentration improves, unlike dementia. And finally, one of the major signs of depression is recurrent thoughts of death or suicidal thinking. So how common is depression? Some research suggests that up to 25% of women and 12% of men can expect to be depressed at some point in their lives. I suspect that that number for men is probably artificially lowered, because men often manifest depression as anger and irritability versus what we typically think of as depression, sadness and crying. About 20 to 25% of people with major medical illnesses will develop depression during the course of those illnesses. Remember when I said that there are some instances when a measure of depression is a normal reaction to life events? Well, a major medical illness is one of those life events. When I was working in long-term healthcare, skilled nursing, I would often be called in to speak to a patient, and they had never seen a mental health professional before in their lives, but maybe they fell at home, they broke their hip, they ended up in the hospital, and now they discover that they're going to be in inpatient rehab for the next 90 days. And that's a lot to take in all at once. Or maybe your eye doctor turns around and tells you, hey, you're developing macular degeneration, and we're going to need to do this series of treatments for you for the rest of your life. That's also a lot to take in all at one time. So while there does not appear to be a physiological link between depression and AMD, depression in the AMD population is very common. As many as 1/3 of those with AMD may be depressed. So what I mean by a physiological link is there's no evidence that AMD causes any changes in neurotransmitters, which are the chemicals in our brain that affect mood, and a whole bunch of other stuff too, but affect mood and have been linked to depression. So AMD does not directly affect the brain chemistry in a way that would cause depression. It's often the changes in one's life due to AMD that can lead to someone becoming depressed. So what causes depression? Well, there are a lot of theories about what causes depression. So genetic influences are believed to be about 50% responsible for the incidences of depression. And environmental stressors are believed to be responsible for the other 50%. So stressors can include illness, marital discord, grief and loss, taking care of sick loved ones, financial difficulties, medical illness, etc., etc. Um, and when I say grief and loss, I don't mean grief and loss just over the loss of a loved one. Grief and loss also includes loss of function. As we get older, especially if we're diagnosed with a medical condition that causes restrictions and limitations to our function that we're not used to, we undergo a process of grieving for that loss of function. So, regardless of the cause, depression is often associated with changes to the neurotransmitters or chemical messengers in our brain, particularly serotonin, which provides a sense of well being and calm. So, some of you may have heard of medications like Prozac or Zoloft. Those are SSRIs, selective serotonin reuptake inhibitors. And in English, what that means is those medications increase the amount of serotonin in our brain, helping us feel this sense of well being and calm. There's norepinephrine, which provides energy and arousal. And there are medications, newer medications called SNRIs, selective norepinephrine reuptake inhibitors. And those increase the amount of norepinephrine in our brains. There's also dopamine. Dopamine is involved in feeling pleasure, motivation, and reward for adaptive behavior like eating, working, sex, drinking. All the things that are considered adaptive release dopamine. And there are medications out there that will also impact the reuptake of dopamine, which will increase the amount of dopamine present in our brains. SNRIs and medications that impact dopamine are particularly good for people with lethargic depressions, apathetic depressions. Serotonin, so SSRIs are typically better for people that have more agitated depression because serotonin helps us feel a sense of calm. So what are the links between AMD and depression? Now, remember, I said that there's no physiological link between AMD and depression, but there are a lot of psychosocial links. So links involving the impact of AMD on our lives. And remember, environmental stressors are responsible for at least 50% of the incidence of depression. And AMD is certainly a stressor. So the limitations and restrictions associated with AMD can seriously impact the quality of a person's life, especially if the condition is not caught early. Larry was just telling me before I gave this presentation that, because he went for a yearly eye exam, his AMD was caught right in its infancy. So he's had hardly any vision loss. People with minimal vision loss have a lower incidence of depression than people who have more moderate or severe vision loss caused by AMD. So it's the impact on lifestyle that often leads to depression among those with AMD. Compared to people without sensory impairments, those with impaired vision are about twice as likely to report being depressed. The prevalence of major depressive disorder in visually impaired samples aged 60 years or greater ranges from approximately 5 to 7%, while in community studies, the prevalence rates are just under 2%. So what that means is at any one point in time, About 5 to 7% of people who are visually impaired will be depressed. Whereas at any one point in time, so we're not talking about lifetime prevalence, we're talking about at any one point in time, the general population, only about 2% are depressed. So among visually impaired older adults, those with AMD are at even higher risk for depression compared to those with other eye diseases. So when comparing rates of depression in older adults with AMD, glaucoma, and a form of corneal dystrophy, the highest rate of depression is found among the AMD group, 39%. So that's about a lifetime prevalence right there, 39%. When treatment results fall below expectations, rates of depression are even higher among those AMD patients who received VEGF treatment. So we're talking about wet macular at this right now. So think about it. You find out that you have macular degeneration, and then they tell you, well, we have this treatment that can help preserve the vision that you have left. And then that treatment falls below your expectations. You're dealing with yet another disappointment. And that's why rates of depression are even higher among those who received VEGF treatment, and that treatment falls below their expectations. Over time, depression is associated with more perceived functional limitations in those with AMD, despite no link to actual visual acuity. So what does that mean? What that means is people who are depressed have convinced themselves that they're more functionally limited than they actually are. Because for people who are not depressed, they perceive themselves as more functionally independent, even though there may be no difference in visual acuity between the depressed population and the population that's not depressed. So I'll say that again. Depression causes people to perceive their vision loss as more impairing than people who are not depressed, regardless of the amount of vision loss they've actually experienced. So what we're talking about here is how people understand and perceive their condition and their ability to function in the world. And I just want to say that is what depression at its core really does. It affects people's perception of their reality. It doesn't change the reality. The objective reality remains the same. It affects our perception of that reality. And I'm gonna discuss that more as we go on. So how does depression affect those with AMD? I like to call this part stinking thinking. Action subtraction, and stealing feelings. So what is stinking thinking? Stinking thinking is, once again, how we perceive what is happening to us and the thoughts associated with those perceptions, how we understand what this disease is doing to us and what that's going to mean for our future and our relationships. Action subtraction, that is my favorite picture, by the way, of all time. Action subtraction talks about the lethargy and lack of motivation that can come with depression. We do less, and therefore we feel worse because we're not doing the things that we used to enjoy. People will often say to me, clients will often say to me, well, I'll wait till I feel better and then I'll start seeing my friends, or then I'll start exercising. That's not how this works. You have to start seeing your friends and start exercising in order to feel better. And lastly, stealing feelings. Feelings associated with depression are often toxic, and those include anger or resentment, sadness, and most importantly, guilt and shame. So we're gonna elaborate on these one at a time. So let's start with stinking thinking. Depression changes how people view themselves, the world, and the future. And not surprisingly, so does AMD. AMD requires, especially if the AMD hasn't been caught very early, it requires a change in how we perceive ourselves and our relationship to the world. Depressed people often experience chronic negative thoughts based on negative assumptions about themselves, the world, and the future. And the reason why negative assumptions are so dangerous is we don't question them. You know, these assumptions are often automatic and unconscious. You know, so people that are generally adaptive and highly functioning will assume that their futures are going to be bright, that the world is inherently a positive place, and that people are inherently good unless it's proven otherwise. People who function more poorly or struggle with depression often assume that they are of low worth, that the world is not a kind place, and that the future looks bleak, and that people in general suck. To put it succinctly. And they have to be proven wrong repeatedly in order for them to change those negative assumptions. And those changes are very difficult to make and don't often generalize to other situations. So in other words, they can be proven wrong time and time again, where people are treating them kindly or being helpful, but as soon as they have a negative experience, it erases all of those positive experiences from their mind. So when trying to adapt to the limitations imposed by AMD, negative thinking, especially about oneself and the future, can become more common. For many with AMD, it's just difficult to readjust and reestablish their self-esteem, security, and positive picture of themselves. What makes the adjustment particularly difficult is that AMD is most common in older individuals. So as we get older, adjusting to new circumstances also becomes more and more difficult. So the way to combat these negative thoughts and assumptions is to become aware of them and challenge them when you notice they are creeping up. And that's harder than it sounds. You know, these negative thoughts and assumptions are often automatic. They don't take a lot of effort. They just pop into your head. Challenging them and becoming aware of them requires planning and thought. It requires effort. It requires looking at the evidence of our lives. And we're going to discuss some examples of that. So example one, I'm totally alone in my pain at this moment. No one can help me and no one cares about me. I imagine that there are people here when they got the diagnosis of macular degeneration, felt very lonely in that moment. And so the automatic thought is, I am alone in my struggle right now. And we don't even have to consciously think that. We are just reacting like that is the case. The thought can be subconscious. It doesn't need to be in our conscious awareness. for it to be a reality. So, what are some healthy and unhealthy ways to react to this fear, which is common among those newly diagnosed with AMD? So, an unhealthy way is to push the people you love away, right? I'm going to push everyone away. I'll hurt you before you hurt me, or I'm going to protect myself from rejection by distancing myself from the people that want to help. To challenge this negative thought, it's important to look at the evidence in one's life and recognize that we are loved, recognize that we're scared, and that's okay to be scared, but also that we're not alone. Recognize that we have a team of experts and family to guide us through this process. You know, the great thing about being over 65 is we all have health care, right? I say we, I'm not over 65. But, you know, for those of you that are over 65, you all have health care. You all are going to have a team of experts that are available to you to help you through this process. You have family to help you through this process. You do not have to deal with this alone. Like I said before, it's okay to be scared, but it's dangerous to use that fear as fuel to convince yourself that you are alone. Oftentimes, people will go through this process of thinking, well, I wouldn't feel this way right now if I was going to be okay. Or I wouldn't feel so lonely and scared if I had people on my side. So they use that initial anxiety or fear to justify their thoughts. And then it becomes like a snowball effect, right? The thoughts fuel the emotions and the emotions fuel the thoughts. So we really want to pause and examine our lives and look at the evidence of our lives. What is the reality? Because depression can easily pull a veil over that reality, and we only then focus on the negative and ignore all the positive. I hope everyone is following along with me. I'm used to giving these talks with people's mics on so I can hear a little bit of background noise. So I feel right now like I'm talking to myself, but I have faith that Larry would let me know if I was talking to dead air. So stinking thinking example 2. I can't do the things I used to do in the same way that I used to do them. So I can't do those things at all anymore. That's a common misconception among people with chronic medical illnesses, especially when they've initially been diagnosed. So what does that mean? The negative assumption to challenge is, you know, if I am not as functional as I used to be, then I'm useless or worthless. Then I'm not functional at all. It's all or nothing thinking, which is very common with depression. Or you can also call it black and white thinking. Either I'm completely functional or I am completely not functional. So how do we challenge this negative thought? We challenge it by recognizing that we need to adapt to vision loss, that we can adapt to vision loss, and that adapting requires us to do things differently, certain things differently, but not necessarily giving things up. There are certain things that people often have to give up with this condition. But most things, especially for those with, you know, only mild vision loss, most things can continue, you know, we can continue with our normal activities. We just may have to adjust them somewhat. And that's okay. It is okay to feel a sense of loss, grief, or sadness as vision worsens. And you have to give up some activities, especially for those of you with dry macular. It's okay to be sad about that, and it's okay to grieve those losses. And remember, grief is different from depression because grief is a process by which we come to an acceptance. Depression is self-proliferating or self-perpetuating. It's important to recognize that you can participate in new activities. Grieving the loss of old activities and coming to a point of acceptance allows us to open ourselves up to new challenges and new activities. This could be an opportunity to try things we would never think of trying before. Okay, example 3. Hold on a minute. That's interesting. All righty. I'm going to go back. There we go. All right. So example 3, my future looks bleak. This is fear and hopelessness or helplessness talking again, with some guilt and shame mixed in for good measure. So the negative assumption is, the future is all bad and there's no good that I can expect. Once again, it's important to recognize that it's okay to be scared. What's not okay is to interpret that fear as evidence that the future is going to be dark. The future is still what we make of it. How we deal with the condition is up to us. And utilizing the people in our lives, your care team, is critically important in creating a future where we have quality of life. The problem with hopelessness and helplessness is it doesn't allow for us to take action. It doesn't allow for us to be instruments of our own healing or instruments of our own adaptation to this condition. We just sort of sit around and do nothing because we convinced ourselves that the future is dark and there's nothing that we can do about it. This is particularly dangerous here because it puts people in this frame of mind where they just sort of acquiesce to their circumstances and don't take action because they don't recognize their own power. So I want to talk now about action subtraction. Depression can cause fatigue and lethargy, leading to inactivity and even poor hygiene, depending on how severe the depression is. So how do we combat that? Well, a big part of combating that is getting moving by creating a regular daily exercise routine. This is critically important also for anyone dealing with a chronic medical condition, because exercise lowers inflammation across every system of the body. So I don't care what your condition is, moving on a regular basis, even if it's walking, simply walking, will lower inflammation and slow down the progression of most chronic conditions. We also want to make good hygiene a habit by making it part of your daily routine. Even people with advanced AMD can still engage in many activities and exercises, still participate in their own activities of daily living. So you want to develop a routine. When we develop routines, it's a lot harder to shrug something off. do I want to do this or don't I, becomes now is the time when I go for my walk or go for a bike ride or do my water aerobics or, whatever it may be. Now is the time when I do that. Now is the time when I shower. Now is the time when I brush my teeth. Social isolation is also common in both depression and AMD. Sometimes people are embarrassed about the fact that they can't see as well, or they have limitations to their function, or they may need help navigating through a busy restaurant. Social interaction is crucial to all people in order to lead a healthy and satisfying life. We want to avoid the self-fulfilling prophecy that people will let us down, or that people will no longer want to socialize with us. And it's self-fulfilling because if we isolate from people, people eventually are going to back off. They'll get the message and they won't come around anymore. And then it becomes a self-fulfilling prophecy. See, when I got this diagnosis, I knew that it was going to affect my social life. And here we go. Now nobody wants to have lunch with me or have dinner with me or, go to the park or go to the theater. When in reality, it's our own discomfort about our condition that caused us to back away from people. So we want to make social interaction a routine part of our lives. The other great thing about making social interaction routine is it forces us to face the anxieties of being out in the world with AMD. And I know this talk isn't about anxiety, but depression and anxiety often go hand in hand, and people's fear about how they're going to be perceived with AMD can often cause them to isolate themselves and create that self-fulfilling prophecy, and then lead to greater depression because they feel so alone. I had a client once. She had fairly advanced multi-systems atrophy. It's similar to Parkinson's disease. And she had a lot of anxiety about going into restaurants and public spaces because to the general public, she looked like she was drunk because of her balance and her slurred speech. She was often perceived as drunk. So we decided the way to handle this is to make a joke out of it. Because being able to laugh at one's discomfort or laugh at a situation helps us all to put it in perspective, even if the situation isn't funny. It helps us feel a sense of mastery over that situation and control. So what she used to do as she was leaving restaurants, if people were staring at her, she would say loudly to her husband, "Oh, honey, I should not have had that fourth martini at dinner. That went straight to my head." And then, they would chuckle at those people, rolling their eyes. I apologize if you hear that background noise. Apparently somebody is mowing their lawn. What is it? The trials and tribulations of COVID and Zoom. So now let's talk about eating habits. Fatigue and lethargy can lead to really bad eating habits because healthy meals take time and effort to prepare. It takes hardly any effort to open up a bag of chips, right? Or to pop something in the microwave, like a burrito. The way to avoid eating garbage food is to prepare your healthy dishes in bulk and in advance. Like soup. Soup can be prepared in advance with low sodium recipes, and it can be prepared in bulk and then stored and frozen. So can a lot of high protein dishes. They can be stored and frozen. Um, I particularly like to use those vacuum sealers. So you can cook something, vacuum seal it, and pop it in the freezer and pull it out, sometimes as much as a year later, depending on what it is. So um, prepare your meals in advance. If you need help cooking, make it a group effort. Make it an opportunity to connect with your loved ones and those around you. Have fun with it. Avoid caffeine and refined sugar because those will exacerbate any chronic condition. Caffeine, refined sugar will make most chronic conditions worse over time. Many people with AMD struggle to re-involve themselves in previously meaningful activities or to learn new ones. It's crucial to remain involved in life and seek alternative activities when prior hobbies are no longer viable. And you see how this connects to what we were talking about before with the stinking thinking. It is not an all or nothing. Either I have to be able to do exactly what I used to do before, or I can't do anything at all. A big part of managing this condition is adaptation and using the people around you to help you find alternative activities and hobbies if you can no longer do the ones that you're used to doing. So now I want to talk about the emotional component of depression, which I'm calling stealing feelings. The negative emotions often associated with depression are sadness, anger, apathy, guilt, and shame. These emotions can rob people of joy or at times rob them of their will to live. Sadness and anger do have a function. I mean, as does guilt and shame to a certain degree, but sadness and anger are in many ways functional when they are short-lived. Anger lets us know when we're being treated unfairly. It can be a motivator. Sadness helps us process grief and loss. It helps us get in touch with um, those losses and reach a point of acceptance in the short term. But emotions like apathy, guilt, and shame, they're particularly destructive because those three emotions often prevent people from making positive changes in their lives. Sadness and anger, like I said, can be motivating, can help us process loss, can let us know when we're not being treated fairly. But apathy, guilt, and shame, they are predominantly destructive and have very little use in our daily lives. So I want to talk first about apathy. Apathy, which is often associated with fatigue and lethargy, results in a sense of emptiness inside, a lack of concern about one's well-being, quality of life, and the future. It's sort of like shutting off your feelings. I'm tired of feeling bad, so I'm just not going to care anymore. I don't want to face what I'm feeling after a diagnosis of macular degeneration, so I'm just going to shut my feelings off and I'm not going to feel anything. I don't care. The problem with that is then we don't get to feel any of the good feelings either. We don't feel anything. We're like dead inside. So it's important to process the grief and loss associated with a diagnosis of macular. And also to recognize the good that remains in life and be able to partake in those happy moments and experience the joy that comes with life, even with limited vision. So examples of apathy are, I don't care if I live or die, so why bother exercising or eating right? Or I don't care how I look, so why bother showering or getting dressed? To avoid apathy, once again, set up an automatic routine of exercise, healthy meals, and good hygiene. Sorry. Also set up a routine of socialization. When we are engaging in activities that we feel good about, or spending time with people that help us to feel good, then we're much less likely to become apathetic and more likely to talk about our feelings regarding anything really. But in this case, it would be macular degeneration. It helps us to process those feelings and allows us to experience joy and satisfaction of being able to still engage in our lives. Guilt. So guilt does have a function, but as a Roman Catholic, I have to tell you, guilt is probably more toxic than it is beneficial. Unless one of you out there in the audience happens to be a sociopath, in which case guilt is a good thing. So guilt often keeps people trapped in negative or destructive relationships because of a sense of exaggerated responsibility. A big part of guilt is taking responsibility for things that we have no control over. And I will tell you that feeling responsible for a situation that you do not control is maddening. Maddening. So examples, my wife now needs to manage our finances because I can't see well enough to write checks. I have failed her. That is feeling responsible and feeling a sense of guilt over a situation that really is out of one's control. Especially if one has dry macular and the condition is progressing, we can only do what we can do. And what's really toxic about situations like that is oftentimes, in this example, the person never talks to their wife about it. They just sort of hold that feeling and feel that guilt and never address it because they're afraid to address it because there's a part of them that feels like, well, what if my wife agrees that I have failed her? That never happens, by the way. No, I've never seen a spouse agree, yes, you have failed me. But that feeling doesn't have to be based in a rationale, right? It doesn't have to be based on rational reality. So it's important to address it and then give yourself, in this example, your wife, the opportunity to challenge that feeling. No, you are not failing me. You are doing everything that you can, and I appreciate the effort and how hard you're working. Another example is if I tried harder, I could have slowed down my vision loss. No, that is not the case. But people, it sounds ridiculous when I say it out loud, but people often subconsciously operate with that assumption. I'm weak somehow. Why did this have to happen to me? What did I do wrong? And the reality is, forgive my French, but shit happens. We don't control all of the bad things that can possibly happen. We walk around for much of our lives with the illusion that we are in control until something devastating happens, and then we recognize how little control we have. But people don't like to accept that sense of being less in control of things. So they'd rather carry around guilt for years and years and years than recognize that, we are only human. Our abilities are limited. Another example is my husband is struggling with my vision loss, and it is my fault that he can't accept it. No, it is not. In my practice, I deal with caregivers predominantly. And one of the first lessons that I teach those caregivers is, you know, if your spouse has a chronic condition and you can't accept that chronic condition, that problem is your problem. It's not your spouse's. So if you, as the person with macular degeneration, are doing everything that you can to make it as easy on your spouse as possible, then your spouse's emotional struggles are their emotional struggles. You can let them know that, you know, you support them and that you're there for them to listen and help. But in the end, it is your spouse's struggle. And it is up to them whether or not they are going to deal with that struggle. You cannot fix that struggle for them. Because we do not control other people. I repeat, we do not control other people. Even me, with, you know, 25 years of schooling and 15 years in the field, I do not control my clients. It is not up to me to force them to do something that I've suggested. That's on them. And if I felt like I was a failure because they didn't take my advice, then I would definitely not be in this field. So how do we combat guilt? We recognize that we may be carrying the burden of responsibility for someone else's problems, or that we may be taking responsibility for a situation that is completely out of control. And we have to consciously tell ourselves that. Once again, examine the evidence of our lives, because depression is an inherently irrational condition, right? It pulls that veil over our eyes and we only see the negative. It warps the reality. So we have to challenge the depression and challenge the depression's version of that reality. No, I am not responsible for my loved one's feelings. I am not responsible for my vision loss. You know, as long as obviously we're doing the things that we can do to mitigate the condition. Okay, shame. Shame involves the expectation that other people will judge us, right? So guilt is a very sort of internal process, right? Where we are judging ourselves. Shame involves the expectation that other people will be judgmental. Shame is particularly disruptive because it often prevents people from ever seeking any kind of help. You know, given the population that I work with, which is mainly, you know, older individuals from predominantly the Midwest, they're often, what's the word I'm looking for? Reluctant to come to a therapist. You know, even if they're, you know, until their problem gets really out of hand, they don't want to go to a therapist because they feel like that's admitting some sort of a weakness. You know, and there's shame involved still in some parts of the country, I suppose. There's shame involved in seeing a therapist. You know, I'm from metropolitan New York. Everybody's got a therapist. Nobody cares that you see a therapist. In fact, if you're not seeing a therapist, people kind of feel like you might think you're better than them. So it's sort of a negative if you're not seeing a therapist. You know, like, what do you think? You're too good to see somebody? So it's just really interesting how different regions of the country can perceive therapy so differently. So examples, I don't need a shrink. I'm not crazy. You know, I can solve my own problems, or I don't want to share my problems because I don't want to be judged. The great thing about therapy is there is no judgment. You know, I'm not in your life. I'm not personally involved in your life. And so it allows me an objectivity that you, being the center of your own life, don't have. And it allows me an objectivity to hear what you have to say without judgment. And the idea of, you know, needing a shrink, because one is crazy. I used to run into this a lot in skilled nursing, because the patient would say to me, "Well, why are you here? Why is there a psychologist in my room? I'm not nuts." And I would say to them, "Well, I'm here specifically because you're not quote unquote nuts. Ethel in the bed next to you has dementia. She thinks she's on a cruise right now. She doesn't know where she is, and therefore she's happy as a clam." Um, but there are situations where being perfectly quote unquote sane results in feeling a measure of depression. So, to minimize shame, we need to recognize that people's struggles are often very similar. Typical struggles might revolve around feelings of insecurity, loss of independence, resentment towards loved ones, failed aspirations, difficulty coping with loss and grief, including the loss of function, as we discussed. You know, like I said, I've been doing this now for 15 years or more. Everybody's story revolves around the same things. I rarely, if ever, hear anything new these days. So, no shame. So, before your depression starts, how do we prevent it? And I want you all to remember miss movement. So, activity, 15 minutes or more walk every 3 hours will help to lift your mood. And there is science behind this. Not only will a 15-minute walk every 3 hours lift mood, it will improve cognition, it will improve bone density, it will regulate blood pressure, it will lower cholesterol, it will improve muscle tone. The list is endless. It lessens the impact of chronic conditions on our bodies. The list really is endless. It helps to regulate weight. I could keep going on. That is number one, the most important thing one can do. And it doesn't have to be walking. It can be swimming, it can be a recumbent bite. I don't care what it is, as long as you're moving. Intake, diets high in fresh fruit and veggies, lean protein, and complex carbs will help keep your brain and body healthy. Avoiding refined sugars and simple carbs will also help to keep your brain and body healthy. Those fresh fruits and veggies have a lot of the enzymes and components that our brains need to produce the neurotransmitters that help us to feel good. Adequate sleep between 5 and 10 hours is necessary for adequate functioning of the brain. The target for most people usually is either 7 to 9 hours. There are some people out there that need as little as 5 and some people that need as much as 10. Our brain requires adequate sleep. If we don't get adequate sleep, what will happen is we will engage in what's called microsleep. This is why people who chronically lack sleep are often grumpy and sluggish and have, cognitive slowing, because their brain is actually falling asleep for fractions of a second every few seconds. Our brain will do whatever it takes to get the necessary amount of sleep. So if we chronically lack sleep, then we owe our brain the sum of the missed sleep. So let's say, for those of you that are working, let's say on Monday through Friday, you only get 5 hours of sleep and you need 7. Then Saturday and Sunday, you owe your brain 10 hours of sleep, and your brain will get it come hell or high water. And I encourage everybody that is struggling with sleep to do some research on sleep hygiene. There's a lot of information on sleep hygiene available on the internet. And sleep hygiene basically is information about how to promote good sleep. Stress, limiting or learning to adaptively cope with stress will help prevent depression before it starts. Once again, how do we cope with the changes in our lives? We rely on the people around us. We communicate our needs. We take care of ourselves physically and mentally. That is how we manage stress. That is part of coping. Socialization, the last S, spending time with friends and family is critical for overall physical and mental health. So remember, it's miss with 3 T's. So how do we treat depression among those with AMD? I'm going to speed up a little bit here. I'm looking at the time. So talk therapy with a professional can help to process the sense of loss and the initial shock of an AMD diagnosis. It can help us develop coping skills and lifestyle strategies to effectively deal with new limitations. Problem-solving therapy groups have been shown to reduce depression in those with AMD. Notice I say problem-solving therapy groups. So groups in which people can throw out the challenges that they're facing because of AMD and have others help them work around those problems and challenges. Medication, Prozac, Zoloft, Remeron, Wellbutrin, Cymbalta, those kinds of medications. ECT or TMS are available. TMS is a newer treatment that involves putting magnets on the skull. It's not invasive. Putting magnets on the skull and running a current through those magnets, a low current. There's no pain involved or convulsions or anything like that. It's not like ECT. But the treatment has been shown to be effective in treating medication-resistant depression. While most patients with wet AMD can achieve positive treatment outcomes from anti-VEGF injections, there are approximately 10% whose treatment outcomes are non-optimal and fall below their expectations and therefore are still at increased risk for depression. So being clear about what one's expectations are and taking an active stance in dealing with failed expectations, if you have failed expectations, is important. You know, being able to lean on those around you, go to a support group, go see a therapist. Don't deal with it alone is the point. Current advances in treatment options have reduced but not eliminated the risk for mental health problems in individuals with advanced AMD. So make sure you seek out all of the treatment options available to you, both for depression and AMD. Behavioral interventions can ease depression for those with AMD, including occupational therapy and the use of low vision adaptive devices. Once again, this is research-based. Getting people in to help us navigate the world is important in terms of feeling like one has mastery over their life and has some control, at least, over the way they deal with their vision loss. For whatever reason, there's evidence of much less depression in Europeans with AMD. This may be related to more assistance available for individuals with AMD in Europe, such as transport services, social welfare programs, and financial assistance. But there are those services available here in the States. They're just harder to get a hold of. So make sure you're using the services that are available to you. Sarasota has tons of transport services, including FISH and ITN and SCAP Plus. So in summary, depression is marked by a change in the way people think, act, and feel. Up to 25% of women and 12% of men can expect to be depressed at some point in their lives. The prevalence of major depressive disorder in visually impaired samples aged 60 plus years ranges from approximately 5% to 7%. When comparing rates of depression in older adults with eye diseases, the highest rate of depression is found in those with AMD. Depression changes how we view ourselves, the world, and the future. Depression can lead to serious health problems as a result of lethargy and lack of movement. And depression is marked by negative emotions like sadness, anger, apathy, guilt, and shame. There are effective ways of treating depression in AMD. Thank you all. And these are the references that are available in case anyone wants to know what references the presentation was based on. And I am now going to stop sharing my screen and make myself available to answer some questions. I'm still wondering why persons with AMD have a higher incidence of depression. Any ideas why? Yeah, so the reason is AMD is a stressor. It impacts our quality of life. And whenever a person is dealing with a chronic stressor or a condition that impacts their quality of life, the rate of depression is going to go up. And that's across the board. So people with chronic medical illnesses have higher rates of depression because they're having to deal with their chronic medical illnesses through the course of their, of the rest of their lives. And it limits their function and activities to a certain degree. So that's why AMD and depression are linked, because AMD increases psychosocial stress. So I hope that answers your question. My mother's 98, but very active physically. She is frustrated that she can't do her activities like crocheting, crossword puzzles, painting, etc. As a caregiver, it's been hard to not be able to help her as much. She was diagnosed with AMD, but at this stage, should she follow up with an ophthalmologist and do anything? Well, I don't know if it's wet or dry. If it's wet, she should definitely be following up with an ophthalmologist for ongoing treatment. I would say try to do the best that you can in giving her adaptive equipment to help, like crossword puzzles in large print format, if she can still do that, or if she loves to paint, to continue painting, but on a bigger canvas, and maybe take up impressionist painting that doesn't require so much attention to detail, or to try alternatives to painting. There's a lot of creative alternatives, including doing tile work, tile mosaics, or using fully sized tiles to create artwork. There's tile painting. My fiance happens to be big on crafting, so there are tons of variations on painting that she could utilize. I would also encourage the use of adaptive electronics. So if she wants to do crossword puzzles, there may be crossword puzzles available that can be filled out by voice command. I'm not certain about that, but I would certainly look into it. I would also check out Lighthouse for the Blind. Lighthouse for the Blind is an incredible organization based in Sarasota that provides a lot of instruction and adaptive equipment for people with limited vision. So I hope that answers your question. I'm scared because I'm single, live alone, and family lives far away with their own problems. I am feeling many of the issues since my diagnosis a month ago. My social circle is small. I worry about care should my AMD continue progressing. I exercise daily, eat right, and I'm hopeful. I've also engaged a counselor to help me through this depression. Well, that's wonderful. That's all terrific. And that is, more than half the battle right there. That's most of the battle. It sounds to me like you should take some time, because you said you were diagnosed a month ago, so there's still, I imagine, an initial shock of this. But take some time to really think about whether or not you'd want to move closer to family. That's not a decision you have to make now, but certainly one worth considering over the long run. And, thinking about if and when you would feel comfortable moving closer to family, like how bad does the condition need to get, if it continues to worsen at all, because I'm assuming you have wet AMD, but with wet AMD, there's a possibility that it may never progress. But certainly, I would think about the long term, but take time to think about that. Don't feel forced to make these big decisions now. All right, next one. But you stated that it is higher than other eye diseases. Is that right? Rates of depression in AMD tend to be higher than rates of depression in other conditions. I don't know why. It could be that the course of AMD is more variable or complicated, or people are older when they get AMD, so it's more difficult for them to adjust to the condition. But we're not quite sure why people with AMD have higher rates of depression than other eye diseases. But I can tell you that there is no physiological link between the disease and depression. At least there's no evidence of that from the research currently. All right, and last one. I guess my question is, how do you find out about services available near me? So if you're talking about services for people with visual impairments, I would again go to Lighthouse for the Blind. They'll be your best resource. For mental health treatment, especially people who specialize in chronic illness, or specifically AMD, your best bet is psychologytoday.com. Psychology Today is a comprehensive mental health website where you can screen through hundreds, sometimes thousands of providers in your location, and you can narrow down your search based on people's specialty. So I would do a search of people who specialize in chronic illness, and then, or maybe narrow that down by searching for macular degeneration in the search box. So I hope that answers your question.
Great presentation, Angelo. We're grateful for your great integrity and knowledge, and we thank you for participating.
Oh, you're most welcome. It was my pleasure.
Okay. Everybody have a good day. Stay healthy.